Hi, my name is Pete Sloan, and I'm a pulmonary and critical care physician practicing out of Baltimore, Maryland. I'd like to complete the third talk in a three-part series on mechanical ventilation. In this presentation, I'll discuss ventilator patient asynchrony, the basics of ventilator alarms, weaning strategies, and the principles of non-invasive ventilation. In parts 1 and 2 of this series, I reviewed background information on mechanical ventilation, lung mechanics, ventilator-induced lung injury, PEEP, and modes of ventilation. If you missed these, they can be found on my YouTube channel, Peter Sloan MD. Also, please feel free to check out my other videos on basic critical care medicine topics at my YouTube page, Peter Sloan MD. So let's start with ventilator asynchrony. Ventilator asynchrony is a common problem where phase of delivered breath by the ventilator is mismatched with the patient's respiratory effort. Sequelae of ventilator asynchrony include dyspnea, increased worker breathing, and prolonged time on mechanical ventilation. Asynchrony can be caused by a failure of the patient's effort to trigger a breath, insufficient flow to meet the patient's demand, also known as flow starvation, high pressure support or tidal volume settings, prolonged expiratory time, and a high pH. So here's a graph of a patient that has asynchrony on the ventilator. We're using in this mode assist control volume controlled ventilation. I reviewed this in talk number 2, but in this mode we deliver a set tidal volume, in this case 450 Cs, with a set flow pattern. We're asking the ventilator to ramp up the flow early to 70 liters a minute and then ramp down on a straight line. So the flow pattern is set. This will be the flow to the patient, whatever the effort is. In this case, the patient is pulling, pressure goes up as the flow goes in, but in the middle of the effort, the patient's pulling in very hard and the patient's exceeding the flow so that they're creating negative pressure by a suction or vacuum effect. Whenever we see this pulling in of pressure in the mid-breath, it almost always means the patient is asynchronous. Um, So in this case, we tried placing the patient on pressure support. In pressure support, another mode I went over, the patient spontaneously initiates the breath with an effort, and the breath continues for the duration of the patient's effort. The patient determines their own flow requirements. It's not a setting on the ventilator. Notice that the ramp right here is only set for manual inspiration. It's not part of the pattern. Neither is the peak flow. So in this case, we could see the patient actually demanded high flow for much longer. In the last slide, I'll go back one slide, you could see the flow was going down throughout, but on the current pattern, the flow was maintained high, so there was adequate flow for the patient to get his volume demand. Another mode we've more recently moved over to is pressure regulated volume control ventilation. Other modes are called VC plus on different, or there are other names for this. But in this mode, we actually pick a target tidal volume of 600 and an inspiratory time, but we don't pick the pressure. We allow the pressure to be adjusted over time up or down in a pressure controlled style to meet this current tidal volume, but in this case you can see there's also much better synchrony. The flow is maintained high in the mid flow and all the way to the end rather than ramping straight down. Also, we set a longer inspiratory time of 1.2 seconds before the flow was down to zero by about 1 second. In this PRVC mode, the patient also determines their flow. The cycle length is determined by the ventilator setting. So this patient's also synchronous. So I'm going to go over some basics of ventilator weaning. It's a whole topic onto itself, but I thought I would go over a couple slides. Weaning, I would define as the process of gradually shifting the work of breathing from the ventilator to the patient. Weaning methods include spontaneous breathing trials with pressure support going down to minimum pressure support, Let me just say that again. Spontaneous breathing trials with pressure support set at minimum, tube compensation trials, or flow-by trials. Another mode of weaning is pressure support ventilation weaning, starting at a higher pressure support where the patient's mostly supported and slowly weaning down to minimum. A third mode is IMV, which was designed in the 1980s as a weaning mode, but over time did prove to be an inferior mode of weaning relative to spontaneous breathing trials and pressure support weaning. So we're not using this as a weaning mode, but it is a possible way to wean the ventilator, mostly on a historical basis. Bi-level ventilation can also be used as a weaning mode by dropping the level of bi-level over time, the high pressure, and stretching out the interval. So here's my illustration of work of breathing on a patient on a ventilator who will be on an IMV mode. Again, we're not using this anymore as a weaning mode, but it's a good illustration. At the beginning, they're on the ventilator, so virtually all of the work of breathing, this much work of breathing is done by the ventilator. And what we do in IMV is we slow the ventilator rate down. The mandatory rate gets slower and slower and slower, and in between the breaths, the patient breathes spontaneously. They tend to take smaller breaths. They may do less work on an individual breath than the ventilator, but over time, as the ventilator rate approaches zero, the patient's weaned off the ventilator. I know I'm repeating myself, but this was a very common style of weaning in the 1980s and 1990s. The next mode of weaning is a very commonly used weaning mode right now, proven to be an efficient mode of weaning called spontaneous breathing trials. We take a patient that's fairly rested on a ventilator and we take them off the ventilator completely for a limited amount of time, let them breathe spontaneously, and if they do well or even if they do poorly, we might place them back on the ventilator later on in the day, take them off for a longer trial, and extend the amount of time off of the ventilator over the course of the day or several days until they're independent of the ventilator. A third mode of weaning is gradual Third style of weaning is gradually shifting the work of the breathing from the ventilator to the patient. So, two modes I'll talk about that are able to accomplish this are pressure support ventilation and proportionate assist ventilation. But the theory is that a patient that's on the ventilator, we can switch over the ventilator breath by breath, so a higher proportion of the work of breathing is done by the patient. In this case, about half of the work is done by the patient over here until we've turned the ventilator down so that most of the work of breathing is done by the patient, and the only work left done by the ventilator might be approximately equal to the work to overcome tube resistance or tube compensation. So this is a nice smooth way of weaning, also fairly popular, but probably in the past 10 or 20 years, a secondary mode of weaning, with the main mode of weaning being spontaneous breathing trials. So here's the theory of weaning. Um, Bi-level, I mentioned, can be used as a weaning mode. I went over bi-level in my earlier talk, but just a quick review. Bi-level is a pressure control ventilation where the pressure oscillates between a high pressure, which is right over here, and a low pressure. Frequently, we keep the pressure low for a short amount of time. It's called a release breath to help maintain high mean airway pressures. In bi-level ventilation, the patient's allowed to breathe spontaneously at the high level or spontaneously at the low level. And they return tidal volumes of two types. Their own tidal volumes might be smaller tidal volumes, and then the release breath can release a larger tidal volume. To wean bi-level, we simply drop down the high pressure closer to the low pressure and lengthen the interval between breaths, or another way to say that is to decrease the respiratory rate. So in this first slide, I have a high pressure of 35, a low pressure of 10, and a rate of 15. The difference of the pressure is 25. That's how much pressure we're going from 10 to 35. The rate of 15 means there's going to be a breath every 4 seconds. To wean bi-level, we simply drop and stretch the interval. So we just drop the pressure, stretch the interval, we drop the pressure. Now it's 10, from 10 to 20 is 10, and we stretch the interval to a rate of 6, which is 10 seconds. We drop and stretch until they're off the ventilator. So in any event, bilevel weaning is a level of support we can use for poor oxygenation patients to maintain high mean airway pressures, but a lot of people don't think of it as a weaning mode, but we've used bilevel weaning as a very successful mode of weaning, sort of non-traditional, but it does work. So one slide on ventilator alarms. Ventilator alarms are a backup system so that we can have the ventilator itself keep an eye on the patient when we step away from the machine. And the theory is we pick parameters to watch, such as minute ventilation between 3 and 30, that will always display the current value. Currently, this patient's 17.7, and if any of these parameters go outside of the range, there are several levels of alarm. The first time it happens, it might be a light comes on. The next time, the light stays on. The third time, an alarm goes off. And the fourth time, if it prolongs the ventilator alarm state, there might be a continuous, loud, noxious alarm that will catch anyone's attention. Um, a couple of other things about ventilator alarms is they are a very nice way to detect a vent disconnect. For example, if you look at the peak pressure is at 50, that's to make sure that the ventilator doesn't push too hard. If the patient bites on the tube or has a mucus plug, we don't want the ventilator to push a pressure of 80 to get the tidal volume of 600 in. We create a limit. But in the example, if the patient disconnected from the ventilator would be able to deliver 600 cc's with virtually zero pressure at the proximal airway. And the hitting a very low pressure alarm can be a sign of ventilator disconnect. Well, as you can imagine, these alarms are tricky. They're managed by respiratory therapy and they have to be set up. If they're set too sensitive, they'll ring too often and you'll get I'm sorry, you'll get alarm fatigue. People will just ignore it. And if they're not set tight enough and they're insensitive, you can miss an important event such as a disconnect or mucus or tube changes that would cause high peak area pressures. So setting these ventilator alarms is really an art. Um, remaining The remainder of any discussion about alarms is not only outside the scope of this talk, but it's really a respiratory therapy topic. Most pulmonologists are really not overly involved in the alarms. They just sort of glance over at the machine, see what's alarming, and then move on to their next patient. Um, Once somebody has been weaned from the ventilator and is independently breathing through the circuit with minimal support, we want to consider extubation. There's really no hard science as to extubation criteria. It's really years of experience and some very basic observations about chances of success of extubation. We know that if we wait till we're 100% sure someone's fine, we'll be prolonging extubation. So whenever we extubate someone, we're taking a small chance that they'll need to be reintubated. We're just trying to minimize the chance of reintubation. So the decision as to when to extubate after a successful spontaneous breathing trial depends on our bedside assessment of the patient's ability to protect themselves from aspiration. So what we look at before we extubate someone who has had a successful spontaneous breathing trial is their level of consciousness. We could look at their cough strength measured by the flow generated to a cough. Over 60 is certainly a good cough and over 35 is usually acceptable. That's 35 to 60 liters per minute. Remember, when an endotracheal tube is in, patients actually can't truly cough because they can't close their glottis. Their glottis and their vocal cords are held open by the endotracheal tube. Some people technically refer to a cough maneuver on a ventilator as a huff, H-U-F-F maneuver. You sort of just blow out the air without closing your glottis. Another factor to consider, of course, is excessive secretions. A typical value is over 2.5 cc's per hour and would be considered excessive. The quality of secretions, tenacious and thick. Frequency of suctioning is commonly used. patients that require Q 1 to 2 hour suctioning usually don't do well after extubation, although if they're alert and have a very strong cough reflex, I wouldn't necessarily not extubate someone just because they're being suctioned every 1 to 2 hours. Another fallacy is, or another confounding factor is that the tube itself does contribute to the frequency of secretions. So removing the tube can actually paradoxically improve the amount of secretions. So the tube itself perpetuates need for suctioning to some degree. Another thing we sometimes think about is cuff leak test to look for the risk of post-extubation airway edema. So the idea is if you can deflate the cuff and the person can breathe around or talk around the tube when the cuff of the tube is deflated, it implies there's a lot of air space left, that's not a tight fit, and that the airways are not swollen right up to the size of the tube. The problem with a cuff leak test is that although it's fairly sensitive to successful extubation, it's not very specific. We have people that fail a cuff leak test but do fine. A couple of ways you can get over that complicating factor is we might not want to do a cuff leak test in someone that's only been intubated for a day or two. If they're a low risk patient, the chance of a falsely abnormal cuff leak test is much higher based on Bayesian probability because we have a low pretest likelihood. So I would not necessarily do a cuff leak test on someone that's been intubated just 1 or 2 days. Another thing we can do on the other end, if someone's been intubated on the tube a couple of days and they fail their cuff leak test, I wouldn't necessarily not extubate them, but a lot of practitioners give a moderately large dose of dexamethasone or another corticosteroid, such as about 10 milligrams of dexamethasone, and at least delay extubation for 6 to 8 hours until the steroid effect takes hold. So this cuff leak test is a very inexact science and has to be really taken with a grain of salt, but it has some utility as long as you understand its limitations. Uh, Once we make a judgment call about all of this, and we should extubate patients and not leave the tube in any longer than necessary. And our final thoughts on extubation is it's better to extubate someone that's marginal, that doesn't need the ventilator and have to reintubate them than to not extubate them because if you never extubate and give someone a trial of extubation, you'll have a higher tracheostomy rate in your ICU population. I have one slide on non-invasive positive pressure ventilation. It's really not the main part of mechanical ventilation, but the idea is it's still mechanical ventilation with positive pressure. What's changing is the interface is now a face mask or a nasal mask interface to connect to the ventilator. So the big difference between NIPPV and mechanical ventilation, the standard, is the access to the airway doesn't involve endotracheal or tracheostomy tube intubation. So we like to use NIPPV in patients with acute respiratory failure in order to avoid tracheal intubation, shorten the time on ventilator, shorten time in ICU, and perhaps improve mortality. There have been some studies in the 1990s going into the 2000s that show that if you use this paradigm of trying to avoid ventilation, intubation, you can actually have better outcomes across the board. We also use NIPPV in a more chronic setting, especially nighttime ventilation in chronic respiratory insufficiency patients. Advantages of NIPPV are patient comfort, speech function, swallowing function, decreased infection rate, avoidance of complications of endotracheal intubation, such as trauma, bypassing defenses, discomfort, and agitation. This is not for everyone. We would not use non-invasive ventilation. We would avoid it in patients with respiratory arrest, hemodynamic instability, unable to protect their airways, excessive secretions, inability to tolerate the mask, or an uncooperative patient. If you have these types of exclusions for ventilation and you need to for these are exclusions for non-invasive ventilation. If you have one of these emergency situations or an uncooperative patient that needs to be ventilated, you simply have to intubate them to protect their airway. Final discussion is high flow nasal cannula oxygen therapy. The setup is actually simple. It's a standard nasal cannula with a tight fit at the nose that a circuit allows high flow rate of oxygen and humidified air at body temperature. Because the air is oxygenated and it's humidified, patients can tolerate flows much higher than the standard 2 to 3 liters a minute on a nasal cannula. We have flows as high as 40 to 60 liters a minute. So why do we do high flow oxygen? First of all, we can get a very high FiO2. On nasal cannula, the oxygen is mixed in with room air, and we tend to be under 35 or 40%. Here we can go up to 100% FiO2 because it's a closed system at a high flow. We take advantage of some beneficial physiological effects. High flow oxygen reduces anatomic dead space by washing out CO2 in the areas of anatomic dead space. High flow flows in so fast that it actually builds up a back pressure be, because it's going in so fast that at first there's a disequilibrium and the flow doesn't quite come out as fast as it goes in until the pressure builds up. We can build up PEEP of about 3 or 4 in the system at the nose and the oropharynx above alveolar pressure. So really it adds PEEP to the system to a small degree. We assure a constant FiO2 because we overwhelm the patient with such a high flow that their own minute ventilation sort of does not change the mixing of room air and oxygen. It's mostly the oxygen delivered from the system. Decreases breathing frequency and worker breathing. The worker breathing goes down to some degree because you're decreasing anatomic dead space by washing it out. Therefore, you're ventilating less per minute, only having to keep up with alveolar ventilation, much less wasted ventilation on dead space ventilation. And because of the humidity and the temperature, mucociliary function is maintained. Anecdotally, high flow nasal cannula oxygen has been quite helpful in hypoxemic respiratory failure, COPD exacerbations, post-extubation respiratory insufficiency, pre-intubation oxygenation, sleep apnea, CHF, do not resuscitate patients, and patients who otherwise would receive BiPAP. In the past several years in our institution, we tend to reach for high flow oxygen before BiPAP. Many patients do quite well, and we would say the majority of the patients that do well find it more comfortable than BiPAP. So we use BiPAP as second line of defense as a way to avoid intubation in patients with acute respiratory insufficiency. So on that note, I want to thank you if you made it through all 3 of my talks. I know there's a lot of information here. Please feel free to go back and review anything that went by too fast, or especially after you go back to the bedside and see some patients. Um, Also, I wanted to remind everyone that I have other talks on my YouTube page, Peter Sloan, MD, PeterSloane, MD, at YouTube. It's right down here. So feel free to peruse my other talks. Thanks again. Bye bye.